This is Premier Global Services. Please stand by. Good day, everyone, and welcome to the Top 3 Gynaecological Cancers, What You Should Know conference call, 5th of the 6th webinar series by Parkway Cancer Centre. Today's call is being recorded. There will be a Q&A session at the end of the presentation. At this time, for opening remarks, I'd like to turn the call over to your moderator for today, Dr. See Hui Ti. Please go ahead, ma'am.
Good afternoon, everybody. Welcome one and all to the webinar that's held by Parkway Cancer Centre. Today's topic is going to be the top 3 gynecologic cancer. I am Dr. See Hui Ti from the Parkway Cancer Centre. The gynecologic cancers, and what does it mean by gynecologic cancer versus women's cancer? Operator, trying to go to the next slide. Okay. Now, you see, in 2005 to 2007, the top killers of Singapore individuals is cancer, and that has been the case over the last 20 years or so, ever since our independence. And that's really because cancer can be considered as almost like the disease of a well-developed country after ischemic heart disease. Now, what is women's cancer? Now, that's very different from gynecologic cancers. Women's cancers are cancers that occur in women, but that doesn't mean that some of the other cancers that occur in men do not occur in women. So in general, when we mention women's cancer, we talk about breast cancer, we talk about womb cancer, or otherwise known as endometrial cancer. We talk about cervical cancer, we talk about ovarian cancer, and we talk about vaginal cancer. In general, that's what is meant as women's cancer. Most of the time, at least, occur in women. Now, breast cancer can occur in men, but rarely, only constituting approximate 1% of all breast cancers. Womb cancer, cervical cancer, ovarian cancer obviously cannot happen in a man. So when we mention the word gynecologic cancer, we actually mean the womb cancer, cervical cancer, ovarian cancer, and vaginal cancer. These are all gynecologic cancers. Now, in Singapore women, the number 1 women's cancer is actually breast cancer. And as I mentioned, cancers that occur in men can also occur in women. So number 2 is colorectal cancer, followed by lung cancer. Later on, with the top 3 uterine or endometrial or womb, ovarian cancer, cervical cancer, skin cancer, stomach cancer, lymphoma, and thyroid cancer. And looking at these statistics are the latest. Now, uterine cancer, ovarian cancer, and cervical cancer statistics have been changing over the last 30 to 40 years. How has it changed? Uterine cancer is becoming more and more common. Cervical cancer is becoming less and less common. And there is a reason for this, and we will go through that in detail later on. Let's talk about womb cancer. That's the number 1, or the most common gynecologic cancer, which is different from the number 1 woman's cancer. As mentioned before, the number 1 woman's cancer is breast cancer, but the number 1 gynecologic cancer is womb cancer, otherwise known as uterine cancer. Majority of the time, the womb cancer involves the lining of the womb. The lining of the womb is what comes sloughed off during the period every month. Rarely are we talking about sarcoma of the womb, which is the cancer of the muscular layer of the womb. That's in 15 to 20. Now, that is rare, and it usually occurs in younger ladies. So today we're really only going to talk about the cancer of the womb lining, or endometrial cancer. Endometrial just means the womb lining. Yeah, this is the lining of the womb. 70% is curable at stage 1, and 30% can be considered as aggressive and can recur even though it is diagnosed as stage 1. Looking at the statistics of womb cancer or endometrial cancer, if we can follow this slide from 1975 all the way up to the year 2000, in the last 30 years, the rate of endometrial cancer in Singapore has doubled. Looking at the age specifics, this is the latest statistics. The chances of a lady getting womb cancer goes rapidly high around the perimenopausal age, meaning around the time when a woman is about to become menopausal. So that's between 40 to 50 years old. And then it dips a little. And then again it goes up between 60, 65, and very rapidly goes down again. The age-specific incidence, which means the chance of a lady getting endometrial cancer, is quite the same as what we consider as the Western country, the other country. What are the risk factors of endometrial cancer? We know that as we grow older, the chances of getting endometrial cancer goes up. We know that if a lady is obese or overweight, the chances go up. We also know that if a lady has got a prolonged period of exposure to estrogen or women's hormones in her lifetime, the chance also goes up. For example, this could mean early menarche. Menarche just means the first stage at which they get their periods, and late menopause, which means they actually finish the periods later. Usually a young lady has menarche at the age of 12 and experiences menopause at the age of 45 to 55. So early menarche would mean something like 7 years old or 8 years old, and late menopause can mean as late as 6 years old. Majority of the womb cancer or endometrial cancer is related to overstimulation of the endometrium by estrogen. And estrogen is one of the women's hormones that controls ovulation, pregnancy, etc. So when there is too much estrogen in the body, whether it's from within the body or from outside, i.e. taking estrogen tablets, this can lead to increased risk of endometrial cancer. So if a person is big size or obese, there is a lot of estrogen production within the body, and this will actually influence the womb to create risk of endometrial cancer. Diabetes is also, especially when it's coupled with obesity, a risk factor for endometrial cancer. Finally, rarely, there are familial cancers, i.e. These are ladies who have a family history, a very strong family history of colorectal cancer and womb cancer at a very young age, and that's rare. Signs and symptoms of womb cancer is very easy to pick up, and that also explains why majority, up to 80% of endometrial cancer is diagnosed early. That's because it is very easy to detect endometrial cancer at an early stage because of its startling symptoms. For example, postmenopausal bleeding. What it means by postmenopausal bleeding would be the following. If I were a 50-year-old lady and I experienced menopause more than 1 year not having any menses at the age of 48 years old, suddenly I have bleeding and it's non-stop. I should immediately seek medical attention because what I have is what I consider as postmenopausal bleeding. Usually, postmenopausal bleeding does not always mean that it's endometrial cancer, but it can. So any lady with postmenopausal bleeding must seek medical attention. For a lady who's younger, irregular menses or intramenstrual bleeding should also seek medical attention. Sometimes this is just due to fibroids, but it's good to get endometrial cancer excluded. Rarely do we see unusual and smelly discharge from the vagina, and even rarer do we see back pain or pain upon urination, pain upon sexual intercourse, or pain and bleeding upon passing motion. That would be when cancer has already begun to spread, so that usually is very rare. So really the take-home message is immediately if there is a postmenopausal bleeding or repeatedly irregular menses or very heavy menses, one should seek medical attention. Now the treatment of womb cancer or endometrial cancer, 80 to 90% is curable by surgery alone because when diagnosed it's as early stage 1. Occasionally, if the histology of this endometrial cancer is a bit more aggressive, one may be offered treatment to reduce the chance of the cancer recurring. Such histologies could be a high-grade womb cancer, uterine papillary serous, clear cell, undifferentiated womb cancer. Sometimes when ladies have such cancers and the stage is greater than 1B or 1C or stage 2, patients can be offered some treatment to reduce the risk of cancer recurrence. But that's not for everyone. For example, very, very early stage, stage 1A, UPSC or clear cell carcinoma can also just be watched or observed over time because the risk of recurrence is extremely small and therefore may not be worth the risk of radiotherapy or the risk of chemotherapy. So what does it mean by adjuvant therapy or treatment to reduce the chance of cancer recurring? I give this example of a 52-year-old lady who has 4 children and she was diagnosed with stage 2 endometrial cancer. After the surgery, the best treatment would be to receive either 4 to 6 cycles of chemotherapy to reduce the chance of cancer coming back in the rest of the body, and radiation to reduce the chance of the cancer recurring within the womb, where the womb used. So this is what we call adjuvant therapy to reduce the chance of cancer recurrence. Now, for ladies who get diagnosed with stage 1, stage 2, or even stage 3 endometrial cancer, it doesn't mean that if they do not receive adjuvant therapy, the cancer is bound to come back. But we're talking about, for example, for a stage 2 endometrial cancer, the risk of the cancer recurring can go anywhere from 20% to as high as 50%. So these ladies may want to receive some treatment to reduce the chance of the cancer recurring, and that's what we mean by adjuvant therapy. Now, next let's look at ovarian cancer. Now, ovarian cancer is also on the increase, going from 1970 to the year 2000. The rates have also doubled. Looking at the age-specific incidences, we are also looking at increasing rates around the perimenopausal age, 40 years old to 55 years old. The risk factors are different from that of womb cancer. We're talking about family history. This is most important. If there's one first-degree relative, there is a 5% risk. But if there's 2 first-degree relatives who had ovarian cancer, it's 10 times more likely. What does it mean by first-degree relatives? First-degree relatives would be, give an example of my own first-degree relatives, this would be my sister, my mother. Second-degree relatives would be my cousin, niece, or my aunt. If one has no relatives, no family history of ovarian cancer, we only run a lifetime risk of 1.5. Reproductive history, these are soft. For example, if we looked at the whole population of ladies who had early menses, never had given birth, had a first child only after the age of 30, or had long duration menopause only after the age of 50, the risk of ovarian cancer also increases very slightly. Is there a good screening test for ovarian cancer? Because the ovaries lie quite hidden in the pelvis, ovarian cancer usually does not cause many symptoms until the disease is advanced. We find this is the case, especially in Western countries where stage 3 ovarian cancer constitutes approximately 70% of all stages. When there is a stage 3 ovarian cancer, patients may experience big symptoms such as abdominal discomfort or tummy discomfort, pressure in the pelvis, pain or swelling of the tummy. That's when it's already begun to spread. Now, in Singapore and other Asian countries, our ladies tend to be smaller, We find that from our own statistics, 50% of our ladies are actually diagnosed earlier, and that's actually very encouraging to know. Screening for the early detection of ovarian cancer really has not been proven to be extremely effective for young ladies. There are ongoing clinical trials looking at best methods to screen for ovarian cancer in ladies who have very high family history or a strong family history. One of the screening tests where many of our ladies may have gone through is this thing called CA125 with varying degrees of accuracy. CA125 is a protein that is produced by the cells lining the abdominal cavity and is also produced by cells in the ovary. It is elevated in ovarian cancer in 85% of the time, but it can also be high when there is no cancer. So if we're looking at screening for CA125, this really can only be more accurate for ladies who are postmenopausal, who have an abnormal ultrasound of the pelvis. It's not so accurate for younger ladies who have no symptoms with a normal ultrasound of the ovary. CA125 can go up when there is when a young lady is having menstruation. It can also go up certainly when a young lady is pregnant. So it being high doesn't mean that there is cancer, and it being low doesn't mean that there is no cancer. It has to be coupled together with ultrasound and symptoms of a lady, and has to be taken into context the age of the lady, have the blood test done. The treatment of ovarian cancer, usually if it's surgically resectable, it should be resected. Lady should undergo surgery to remove most, if not all, the cancer, followed by chemotherapy adjuvantly again to reduce the chance of the cancer recurring. Sometimes in 30% to 50% of patients with very advanced disease, surgery cannot be done adequately. Sometimes it cannot even be done at all. In these ladies, we do offer treatment with pre-surgical chemotherapy called neoadjuvant chemotherapy to reduce the size of the tumors, chemically debulk patients, and to decrease unnecessarily morbid surgery, such as bowel surgery. The cancer will just melt away 70% of the time, and the patient will just undergo simpler surgery. But usually complete surgery would mean complete removal of both ovaries. Even after chemotherapy, they're normal, they still have to be removed, and also removal of the uterus and any other cancers or nodules that are suspicious. Lastly, we're going to talk about cervical cancer. Cervical cancer is of great importance because it's on the downward trend. Now that may sound like a fairly contradictory statement, because if it were not so common, why should I be paying so much attention to it? Cervical cancer used to be very common and is actually rapidly decreasing. From the last 10 years or so, it's decreased by almost one-fold. And there's a very, very simple reason for that, and the simple reason is due to screening. If there were a screenable cancer or preventable cancer, one of them would be cervical cancer. The risk factors are listed here on this slide. Age at first intercourse less than 16 versus more than 19. The relative risk of getting cervical cancer is 16. If a lady had more than 4 sexual partners versus 1, the relative risk is about 3.6 or about 4. If a lady smokes cigarettes, it's about 4, and if they had genital work, it's about 3-fold increase. Looking at the same decrease in cervical cancer. Now, cervical cancer is related in 90% of the time to this infection called human papillomavirus, or HPV. Human papillomavirus infects many millions of people all over the world, and chances of infection is the greatest when a person is approximately 17 to 18 years old. It doesn't mean that if one gets infection with HPV, one will definitely get cervical cancer. Looking at this graph here, slide here, does tell us that many people may get even those HPV that may cause cancer, but some of them will go on to clear the infection And some of these low-grade epithelial changes may just resolve on its own. And only a small percentage of ladies who are infected with HPV will get cervical cancer. From having an infection with HPV all the way to cervical cancer can take anything from 5 to 20 years. And within this 5 to 20 years, screening can happen. And during the screening, these lesions in the middle, or called CIN, can be picked up, treatment can be done, and cervical cancer will not happen. So this is what we mean by total prevention of cervical cancer for a person who previously had infection. So the simplest way of picking up such CIN or infection is using this thing called Pap smear. I'm quite sure that people who are tuned in right now may have had or may have heard of this thing called Pap smear. Put it simply, a Pap smear is a procedure where cells are scraped from the cervix and are examined under a microscope to check for disease or other problems. And this pictures in the middle would be what we're looking for. This picture at the top is actually a Pap smear that is normal. The cells that look like tissue paper, and within the cells is this little black dot. And this little black dot is what we call the nucleus or the heart of the cells. And they're very small. They're looking quite quiescent. As we go on and we see malignant cells here, this is what we look for that is considered as normal. Looking at the same cell, again it looks like tissue paper, but we don't see very much of it because much of it is replaced by this nucleus called the heart. And this is called actively replicating cancer cells. If we were to screen 50 to 60 million women, we probably would only find 10,000 cancers, and the rest of the ladies would have had normal screens or had 2 to 3 billion atypical squamous lesions or low-grade precancerous lesions, and only 300,000 high-grade precancerous lesions. And all these ladies in the middle could have treatment that will prevent them from getting the cancers. So we recommend that ladies have a Pap smear, actually 3 years after or immediately after having started to have sexual intercourse, but not later than the age of 21. Yearly, at least for 3 years until 3 consecutive normal Pap smears. Then they can consider doing it once every other year or once every 3 years. If a lady can screen once every 5 years, we can already reduce the risk by about 84%. And if we can screen once every 3 years, we further reduce the risk by 92%. And if we can screen every year, we can further reduce that up to 94%. If the Pap smear is at normal, one would go on to undergo this procedure called colposcopy. Colposcopy is actually not an operation. It just means that using a microscope, we look clearly at whether or not there is definitely abnormal cells on the cervix. For example, here on the left side is considered as normal all the way to cervical cancer. During the colposcopy itself, punch biopsy can be done, or even a cone biopsy, where a large area of tissue around the cervix size is removed for examination. And sometimes the procedure itself is therapeutic, i.e. if there was a very small patch of CIN, this could be removed as part of the treatment rather than just for examination. And this is what we're looking for. We're looking for cervical intraepithelial neoplasm, or CIN. And that's the changes which are precancerous. Here on the left side are normal cells on histology. Again, looking at tissue paper-like, pink tissue paper-like cells with a very, very small black dot, which is the nucleus, going all the way to CIN3, where we see highly abnormal cells here with very little cytoplasm or tissue paper, but quite a lot of nucleus. CIN can also be referred to as dysplasia. So if we leave CIN in the cervix for a prolonged period of time, this can become invasive cancer. This itself is not invasive cancer. If CIN is found, LEAP surgery can be done, or even cryotherapy and laser therapy can be done to eliminate the cancer. the CIN, so it never becomes invasive cancer. If, however, cervical cancer is still diagnosed as invasive cancer, during the early stage, surgery can be done to remove the whole womb and the cervix, leaving intact the vagina. And for ladies who are postmenopausal, we will remove the ovaries at the same time. For ladies who are premenopausal, we will leave the ovaries in. Ladies with early stage cervical cancer can also undergo radiation with chemotherapy, and that would replace surgery itself. So what does it mean by treatment? If I had a 38-year-old lady who's a housewife and had 4 children, and the stage of the cervical cancer is stage 1, the tumor is approximately 4 centimeters, the best treatment, instead of undergoing surgery, would be to go through this treatment called chemoradiation, where radiation is given over a period of 6 to 7 weeks, coupled with weekly chemotherapy. And this chemotherapy is a bit more special. On its own, this chemotherapy does not cause much harm to the body. On its own, it's got very little side effects. No hair loss, very, very mild nausea and vomiting. What it does is that it actually boosts the effects of the radiation. So it actually has its effects by doing radiation sensitizing. The main treatment of the cervical cancer is the radiation, but the chemotherapy given at a low dose would just help to boost the effectiveness of the radiation. So all the side effects of the radiation may be slightly higher, but in exchange, we get a much better control of the cancer and treatment of the cancer itself. Sometimes the patient may have seemingly early cervical cancer at the time of diagnosis, so surgery is offered. But unfortunately, after the surgery, is found to have a higher stage because the lymph nodes are positive, because margins are positive, or because there is involvement of the side wall of the pelvis. In those circumstances, for example, like this 42-year-old, clinical stage 1, but after surgery is found to have positive lymph nodes, she's upgraded to a stage called the stage 3. So she would require to have chemotherapy and radiation given in a different manner. Again, here the chemotherapy itself doesn't cause much harm. It's the radiation that really does most of the treatment to reduce the chance of the cancer coming back in the same place. And this is the 5FU or the 5-FU pump that we give the patient that very, very slowly this treatment over 96 hours. This is not battery operated. Sometimes we see ladies with quite advanced cervical cancer because unfortunately they did not have the opportunity of going for screening and did not come forward for medical attention when they have had normal bleeding. For example, this 57-year-old lady who's a housewife with 6 children, she's diagnosed to have stage 4A cervical cancer. So the tumor is quite advanced and surgery is not possible. And sometimes radiation is also a bit difficult. So in circumstances like this, chemotherapy can be given to immediately shrink the cancer, followed by chemoradiation, followed by surgery. This is somewhat of a slightly more unusual treatment, mainly because the concern that we always have about a locally advanced cervical cancer is that it can involve the organs around the cervix, in front, which is the bladder, and behind, which is the rectum. If the cancer actually involves both these two organs, there can be abnormal connections that can lead to awful symptoms such as passing urine through the rectum and passing feces through the bladder. This is an extremely uncommon problem, but it can occur when the cancer recurs and is not operable. Of course, when the cancer has spread to the rest of the organs, the only chance that we can actually treat it would be with chemotherapy alone. So cervical cancer is screenable. It can be detected very, very early on, and it can actually be cured simply by simple surgery if caught, especially at the CIN stage. So screening really saves lives. Now, the truth about cancer is that if we look at the principal causes of death in Singapore, number 1 is still cancer, even though we are seeing earlier and earlier stages and we're treating more and more patients and the treatments are getting more and more successful. we're generally seeing more and more cancers because looking at the life expectancy, the individuals in Singapore, just like the rest of the world, is getting higher and higher. As it stands right now, a lady can live to the age of 83 years old and a man to 76 years old. And looking at this graph here, looking at how much we spend, this little red dot is how much we spend per person for healthcare, and this is the life expectancy. We actually share the same life expectancy as people in Canada, in France, lower than that in Sweden, and lower than that in Japan, but we can be considered as number 3 in the world. But yet the amount that we spend per person is actually very little. So this is something to take note. That's because of our fairly efficient healthcare system in Singapore. Despite its problems, we have one of the best healthcare systems in the world. Well, to kick cancer in the butt is, this was quoted by a cancer survivor. She said these 4 things about her early cancer. Her cancer was caught before it spread. She was fortunate enough to have caught it when it was stage 1. She had effective treatment that was available to her. Some cancers, no matter how early, are not associated with don't really have very effective treatment. Most cancers have very effective treatment, so she felt that she was quite lucky to have had that available to her. She had excellent health insurance that paid for all the treatment. But after thinking about it and after surviving this cancer for more than 10 years, she realized that the only thing that she really had the choice of would be to choose to treat her cancer aggressively rather than conservatively and think that it is just for a death sentence. Why she meant that was that, number 1, her cancer was caught before it spread. Sometimes cancer, as I mentioned, cannot be caught early. She had effective treatments available to her. Sometimes for certain cancers that are extremely rare, there are no clinical studies and therefore effective treatments have not been studied. She had excellent health insurance when she could have bought this after she was diagnosed, and so the only thing that she could really choose was to choose to treat it aggressively. Now, some cancers are related to weight. In fact, most cancers are related to weight. This would be my last slide, and I just want to bring home the message that for the top 3 gynecologic cancers, apart from screening for cervical cancer and possibly screening for ovarian cancer, many of the cancers that we suffer, including breast cancer and endometrial cancer, actually is related to weight. The more pounds we put on, the less exercise we do, the more fat content our body has, the less lean muscle, the more risk that we put ourselves through in getting cancer. So the key issue here is early screening for cancers that can be screened, and also to keep a normal weight, not underweight, but normal weight, and also to exercise to increase the amount of lean muscles, to decrease the amount of fat in our body. With that, the presentation comes to an end, and we're open to questions and answers.
Thank you, Dr. C. The question and answer will be held electronically. To ask a question, please press *1 on your telephone keypad at this time. Please state your name and location before posing your question. Once again, press *1 to ask a question. We'll pause for a moment now to assemble the queue. All right, Dr. C, there seems to be no questions at this time. There seems to be no questions.
No, sure, no problems.
As for the chat on the web, we don't seem to have any questions as well.
No worries.
Okay, over to you, Dr. C, for any closing remarks.
Oh, we have a question. Okay, we have a question, operator. This question is regarding screening in womb cancer. Now, I just want to take a little while longer to perhaps let our callers have a bit more time to think about questions to ask. Womb cancer can sometimes occur in ladies who are taking medications to treat another type of cancer. So if we're talking about screening for womb cancer, for ladies who are taking medications that may have a slightly increased risk of womb cancer, we would advise them to get a regular ultrasound of the womb, coupled together with pap smear, and to visit, obviously, the gynecologist once every year to look for thickening in the womb lining, and that would tell us whether or not there's any issues to be concerned about. But with womb cancer, because 90% of them present very early with postmenopausal bleeding or irregular bleeding, sometimes there's no need to do a screening for ladies who are not on medication that unusually increase their risk. So the best screening would be, first of all, to know that if there is irregular menses or postmenopausal bleeding, immediately, not waiting for 1 or 2 weeks, but immediately seek medical attention. For individuals who are on medications that may increase the risk, they should go for 6-monthly or yearly follow-up consultations with gynecologists, do an ultrasound, and to do pap smears.
Right, we'll pause for a moment again to see if there's any more questions. Once again, press star 1 on your telephone keypad to ask a question. We'll pause for a moment now. All right, Dr. C, there seems to be no questions at this time.
There's another question on the chat.
Okay.
This is a private question, so I will just answer on the chat message. I think it's not pertaining to a public question. Can I go ahead and do that?
Yes, no problem, because the public will not be able to see the private chat.
Okay. I've been given the go-ahead to ask this question in public. It's about an individual who has no abnormal bleeding, nor for vaginal discharge, but has a womb thickness of 2 millimeters, and she was asked to have a DNC, or what we call dilatation and curettage, and whether this was okay to proceed. When an ultrasound is done on the womb, it really depends on which part of the period and how old this lady is. Given an older lady, we would expect a womb lining to be very thin. Given a younger lady, in the middle of her menses, would have a thick womb. So having a dilatation and curettage could mean intermenstrual bleeding. That means bleeding abnormally in between the menses. And at the time of the ultrasound, the womb lining may be normal. So even when there is a normal womb lining and an abnormal symptom, gynecologists may want to just take that extra step to be extremely careful to make sure that there are no abnormal polyps or infection or inflammation of the womb lining resulting in the irregularity of the bleeding. So I suggest that this particular individual discuss again with a gynecologist as to which aspect she or he would be most concerned about that she was offered the DNC. So sometimes these intermenstrual bleedings can occur intermittently. So say over the last 6 months, 3 of those menses were related to with bleeding in between, and the bleeding may just be spotting alone. And sometimes they could be benign polyps, benign meaning no cancer, little growth inside the womb, which can cause this irregular bleeding or irregular discharge in between. So that would be the reason why a particular individual would offer the dilatation and curettage. Okay, there's another question from Philippines. A lady who had polyps removed many years ago, whether or not she would be considered as high risk. Polyps by nature are benign, but there are some polyps which are related to what we consider as a precancerous. So let's talk about polyps in the uterus, the womb first. Having womb polyps does not predispose to a higher risk of getting womb cancer. If, let's say, these polyps are due to inflammation, infection, irritation by, say, an IUCD, etc. But if we're talking about recurrently having polyps, then I think this particular lady will need to continue to have follow-up because some of these polyps may actually be due to, for example, overestrogen exposure, whether it be from the body itself or from a medication that this particular individual might be taking. But it doesn't necessarily mean that she's at high risk. On the other hand, if she had an individual had polyps in the colon, I think she should continue to have colonoscopies done because that would be predisposing to colon cancer in 10 years.
All right, Dr. C, just to update you again, there is no questions in the audio section.
Mm-hmm. We're slowly seeing the questions coming from the chat. I think we'll give our friends a little while longer.
All right, we'll pause for a moment again to assemble the queue.
Hello, operator?
Yes, Dr. C?
Yes. I think if there are no other questions from our participants, I'd like to thank everyone who's joined in. And please, everyone is welcome in following up this presentation, our series of presentations from the Parkway Cancer Centre in the next few weeks. All of these will be available on our website, and we will continue to welcome questions to us through the CanHope. Thank you very much.
And that concludes today's conference call. Thank you all for your participation.